Now, hello. I am very happy to give you a presentation on recurrent miscarriage. Um, I'm going to just get straight into it for you, and let's hopefully help to expand your understanding about what is recurrent miscarriage and how do we investigate and treat for this, especially with restorative reproductive medicine and neofertility. For the outline of my presentation, I'm going to first of all give you an overview of the Royal College of Obstetricians and Gynecologists Recurrent Miscarriage Green Top Guidelines and explain what that is. It was published in 2023, so just last year. And then I'm going to contrast their guidelines with key concepts that we apply with restorative reproductive medicine, especially with neofertility. And then I'm going to demonstrate a case report to hopefully explain how our concepts help couples with recurrent miscarriage. So trying to see. This little image, I'm going to put it up at the top. I think that's better. Thank you. Okay, so here we go. Put this down to the bottom as well. So apologies for that little bit of housekeeping, and I'm going to let that hopefully down even lower. Okay. So this is the guidelines published in the British Journal of Obstetrics and Gynecology on recurrent miscarriage. It is open access and freely available to anybody who wishes to read the guidelines. It's particularly directed to specialists who work in the area of assessment and treatment for recurrent miscarriage. And it was published first years ago in 1998, and it's been revised repeatedly, and the most recent revision was published in June of 2023. First of all, the definition of recurrent miscarriage. What is it? Is it 3 miscarriages or is it 2? Well, there are varying opinions as to when we should take this as a serious issue, and it can be rightly argued that less than 2% of the population of couples trying for pregnancy will experience 2 or more losses. So 98% of the population is excluded by that. And my view would be it's reasonable to start investigations and treatment for 2 or more losses. The guide from the Royal College of Obstetricians still stuck with the traditional definition of 3, but they said using your own clinical judgment, sometimes it's more appropriate after 2 losses to begin investigations and treatment. And they say that it doesn't have to be consecutive losses. So if you have a live birth mixed in with your 2 losses, then it's reasonable to begin investigations and treatment. And then they talk about the concept of sporadic miscarriage, where this is quite common to get an occasional miscarriage, and depending on a woman's age, it's the single biggest predictor of the risk of an out-of-the-blue spontaneous miscarriage for no obvious reason, and it's attributed largely to probably genetic factors, especially with aging of female eggs, that you're going to have a higher risk of miscarriage. So the expected incidence of a sporadic once-off miscarriage is about 10% when you're aged 20, rising to greater than 50% at the age of 45. And the difficulty for the assessing clinician is, was this sporadic, or do we think it's more serious? And often a once-off miscarriage, while it's traumatic and all the rest, it certainly would not fit into the criteria of recurrent losses and the investigations that would go with that. It would be inappropriate to begin investigations with just 1 loss. So keep that in mind. But just go through the rest of the ideas with this. Here we go. So the classifications of evidence is really quite interesting because this helps you to understand, when we're reading their guidelines, what level of evidence do they have for a particular intervention. And you get a level of 1++, which is the best of the best study of evidence you could have. So that's a high quality meta-analysis, systematic reviews of randomized controlled clinical trials. So they're all randomized controlled clinical trials for level 1 of varying degrees of quality. And then when you're at a level 2, it's not the randomized controlled clinical trial. It's different types of studies, like a high quality systematic review or case control cohorts, and always trying to take into account the risk of bias or chance, which gives you lower level evidence. And then the level 4 is just expert opinion, and level 3 is case reports or case series. So you can see that while it's useful to have an expert opinion or look at a case report or case series, we're always looking for more and better evidence. And the thing I would just say is, well, bear in mind, it starts at lower level before you get to the higher level. So sometimes we start with just these lower levels of evidence that can be quite convincing, while deeper evidence is still pending. The other thing that's interesting is the grades of recommendation. So that you get A is high level, D is low level, and it's dependent upon the amount of evidence that's available, where they give the grade of recommendation as well. So you can have a 1++ grade A is the best of the best, and a 4D is lower level evidence. And interestingly, sometimes they just recommend best practice based on clinical experience, because there is no published evidence to support what is accepted as best practice. But they try to leave this as infrequent as possible. And they still put the onus to say we must try to look at the published evidence to have objective proof to validate the things that we recommend. So it's using this type of a lens. The specialists within the Royal College of Obstetricians and Gynecologists went through all the published data, hundreds and hundreds of published studies, to see, well, what evidence do we have to say that what we think is an effective investigation or treatment actually is truly effective. So, and it's always good to stress test any ideas or evidence that we do have, because we have to allow it to be scrutinized by our peers to say that do we really have enough evidence to support whatever our practice is. So first of all, what about the level of evidence for the different tests? And one of the big ones that I'd see regularly is the clotting studies. So I think it's still very reasonable for most couples, once they've had 3 consecutive losses, to consider investigations with these thrombophilia or blood clotting studies. And what surprised me is that it's the acquired thrombophilias that are the most important to look for, because that's where the evidence is. So that's the lupus anticoagulant, cardiolipin antibodies, and anti-B2 glycoprotein. So and the evidence for that is not super strong. I thought before I read this that the evidence may have been stronger. So it's only evidence grade C that this test is worth doing. But I would certainly agree with that. And then also what surprised me is some of these more unusual tests are just for second trimester losses for Leiden 5, protein S, prothrombin gene mutation. And things then like your MTHFR, protein C, and antithrombin deficiency, which are genetic thrombophilias. It's not worth even testing those. And the evidence would support that, to say, don't even do these tests because they're of no benefit. They do recommend cytogenetic analysis of pregnancy tissue, which I'd very much agree with, and I was surprised to see it was only evidence grade D. Parental chromosome testing or karyotyping for the mum and the dad, and this is again when you've had 3 losses. My view is that's of limited value because the pickup rate with it is so low. There's only a 3% positive pickup rate with that, and there's nothing you can do to change the outcome. So there may still be some merit in doing that, but it's limited, and somebody has to pay for that test. I would advise them not to do it. Thyroid testing, absolutely agree with that, and thyroid antibodies. I liked to see the 3D ultrasound to look for congenital abnormalities, and the strongest level of evidence for that over and above anything else. And then what I don't like is where they recommend some of these things like immune testing, infection screening, and looking for DNA fragmentation index testing. While there is evidence to support that, it's somewhat limited and it should only be in a research setting. And I think we need to let our patients be aware of this. while we offer these types of tests to people, that this is something that is often recommended for research only, and just so our patients are aware of that. And what's also hugely important is that IVF does not help with recurrent miscarriage, and the level of evidence for that is as strong as the level of evidence to say that you should be doing thrombophilia or blood clotting studies. So this specifically is, and it sounds clever. You say, well, if we make the embryos in the lab and we do pre-implantation genetic testing, and then put the best embryos back, that's really going to help, right? The answer is no. You would think it should, from pure, say, ethics aside, and you're just trying to get a result. And the evidence is that doesn't help with recurrent miscarriage. So that's very useful to be able to point that out to people as well. We've always known lifestyle advice helps. So smoking, alcohol, caffeine, modest amounts of these things, and zero smoking and reduced alcohol intake and caffeine, one, maybe two caffeinated drinks in the day. Supportive care, emotional, psychological support, very helpful, very important. And aspirin and heparin treatment, if you have abnormal clotting studies, that does help. And this is beautiful to see that the level of evidence in favor of giving progesterone support during pregnancy is stronger than the level of evidence for aspirin and heparin. And they say that that's until 16 weeks pregnancy. If you're bleeding in pregnancy, so it's a very specific group, it's not across the board giving it to everybody, but it's been definitely shown to help. If you're bleeding and you're prior to 16 weeks, progesterone is going to make a significant difference. And then this other part is also really important, that if all your testing is normal, do not give aspirin and heparin for unexplained miscarriage. It does not help. And the level of evidence for that is super strong. It's right up at level B evidence. And furthermore, levothyroxine, that's your T4 or L-troxin treatment for TSH. If you have a normal TSH, even if you have thyroid antibodies, you don't need to treat the antibodies on their own. You only treat if the TSH value is also abnormal, and that evidence is super strong. Resection of uterine septum, I've seen that work very well clinically, and they say, well, ideally without it in research, I'm more than happy to recommend that in clinical practice because I've seen it work. So it's good to be aware of these things. And then you have these identifiable risk factors for recurrent miscarriage. And they show there's a strong level of evidence with advancing maternal and paternal age that with advancing age, your risk of miscarriage just goes up. And that's a given. If you've had more previous miscarriages, the more miscarriages you have, the more likely you are to have additional miscarriages. And surprisingly, if you've had a previous live birth, that does not guarantee that you're safe to not have future miscarriages. It doesn't offer the level of protection you would think. And also surprisingly, that people of an African ethnic background appear to have an increased risk of miscarriage, and they didn't specifically identify why. We know that smoking, alcohol, excess caffeine, all associated with more miscarriages. And also, if your BMI is too high or too low, extremes of body weight will increase the miscarriage risk. So it's just great to have solid evidence for these things. You could always reference this to have a good, solid advice that you're giving to your patients. This is interesting because I often see when patients come with, say, 2 or 3 recurrent miscarriages, this predicts your likelihood of having another miscarriage. And it's quite easy to remember the numbers in round figures. So if you've had your 2 to 3 miscarriages, say 3 miscarriages, there's a 30% risk in round figures that you're going to have another miscarriage. If you've had 4 miscarriages, there's a 40% risk, 5 miscarriages, a 50% risk for your next pregnancy, and so on. So it's very round, easy figures to remember in round numbers. And there's 2 ways of looking at this. So often what's recommended is, well, you've had 2 to 3 recurrent miscarriages. You know what? We're 70+% sure you're going to get success if we do nothing at all. So we reassure you, and 70%, well, that's pretty good, right? It is, but if you compare it to the baseline of somebody who hasn't had a miscarriage before, the baseline should only be 11%. So you're almost 3 times more likely to have a miscarriage compared to somebody who never had a miscarriage before. And for me, that's unacceptable. And I think it's all about how we explain it to people. So I would not be at all reassured by being told I've nearly a 3 times higher risk of miscarriage compared to baseline, and somebody who never had a miscarriage. And I think it makes absolute sense, even though you could say, well, with no intervention, we have a 70% chance of a live birth. And the other issue that I've got a concern with on this data is live birth is the only thing that was measured. And our goal with restorative reproductive medicine in particular is not only do we want to get you pregnant and get a live birth, we want a full term, normal weight, healthy mom and healthy baby. And our thinking is if you're having miscarriage, there has to be a reason or reasons for it. And if we identify these reasons and treat these underlying reasons, mom's health is better, baby's health is better. You're more likely to get a full term healthy pregnancy if we treat everything. Our incidence from our clinical experience of things like hypertension, placental abruption, preeclampsia, low birth weight, premature delivery, all much, much lower in the population that we're treating. It's a high risk population that should have a higher incidence of these things, and we would have an incidence that is comparable or less to the normal healthy population because we've dealt with root causes before they get pregnant in the first place. This is also interesting, and again, these are the miscarriage guidelines. That there's no increased risk of miscarriage if you've well-controlled diabetes. And the other one that I'll just look at there is your polycystic ovarian syndrome. Yes, you're going to have an increased risk of miscarriage if you have polycystic ovaries, but there's no guidelines. Oh, well, what do we do about it? We say, well, we know it's a risk, but they haven't proven, well, here's how we intervene to help reduce that risk. And that's something that we're currently working on. And we can see from our clinical experience, we really can make an impact there. Another thing that interested me was elevated prolactin levels will increase your risk of miscarriage. And in fact, I wasn't aware of that. Being 26 years in clinical practice, I was aware of prolactin interfering with your ability to get pregnant, but I wasn't aware of its role that it's associated with an increased incidence of miscarriage itself. I suspect it may be a surrogate marker for stress. And when stress levels are increased, you get high prolactin levels, and that'll increase your risk of miscarriage. And I'd commonly see prolactin come to normal with effective stress management. So I think it's probably a surrogate marker for underlying stresses that need identification. And then breaks my heart to see the inability of my colleagues to measure hormone deficiencies. And they just put it down as luteal phase defect and insufficient, inconclusive evidence. So we have to put our hands up in the world of restorative reproductive medicine to say we have not made a strong enough case to our peers to say that hormone deficiency, which can be follicular dysfunction, not just luteal phase deficiency, but this concept of suboptimal hormones is not within the realm of practice yet of our peers, and something that works for us clinically that will hopefully show you as we progress. So restorative reproductive medicine, I've come up with a very succinct definition. It's medical or surgical treatment applied to male and female as needed to restore optimal reproductive function. We combine it with fertility cycle charting. If you don't have a fertility chart, it's not authentic restorative reproductive medicine. And then we rely upon regular intercourse during the fertile time, and we persist for up to 12 cycles because it's normal to take a year to get pregnant, or a month, or anywhere in between. So one of the deficiencies of our colleagues is that they give up too soon after anywhere from 3 to 6 cycles, and they need to persist for longer. And they need to monitor the impact of intervention better with the fertility cycle charting, with ultrasound and hormone studies, and then allow conception to occur in a favorable environment. So there's a huge amount that needs to change here in the way we understand and manage fertility. And in the world of restorative reproductive medicine, we need to challenge our peers in that direction. Key points with us is, well, what is low? When do you treat? And how do you know how to treat things? Is it a follicle? Is it a corpus luteum? We have a whole list of treatments that we typically would recommend. And we would say, I'm not going to go through the entire list here, but this is a list of multiple things that we can and do recommend. And the difficulty and challenge, and we there have laparoscopy, hysteroscopy there at the bottom, even if there's no symptoms. And that was completely missed by our peers. So we've potential treatment options that aren't even being considered by our peers that have the potential to improve fertility outcomes, and it's based on clinical experience and limited published data. So one of our ambitions is we need to move from our clinical experience to more high quality publications, and because our peers want to solve these problems for the patients who have these problems. But we have not made the case strong enough without publications. So where are we? So this is a case of trying to rediscover the art of medicine, and it's where I had a patient recently who I did very different treatment compared to her first successful pregnancy and her second successful pregnancy, because you chop, change, and adjust and refine the treatment according to what you see. And my view is there isn't just one way to solve a fertility problem. There's multiple different strategies, and we can get there with different approaches. And this is where the art comes in. But our first thing is first do no harm. And these are our treatments that we commonly would recommend from everything from our diet, our supplements, our low-dose naltrexone, our DHEA, our insulin sensitizing treatments, our thyroid medications, sympathomimetic treatment, aspirin with heparin, progesterone, prednisolone, and even now medicinal mushrooms. So that's a sketch of broadly what we would do, mostly focusing on the female side. There's different treatments we recommend for the men. And we need to conduct prospective comparative studies looking at traditional miscarriage guidelines compared to restorative reproductive medicine. And their guidelines have a step-by-step approach. And I would propose we would conduct a study looking at 120 couples in each arm and compare full outcomes. What is the patient experience? What's the cost of investigations and treatment? What about maternal and fetal health throughout the process as well as at the end? What is the incidence of not just live births, but how many weeks were they at delivery? What's baby's birth weight? And what about repeat successful pregnancies, which is something that we'd be very strong on in restorative reproductive medicine. And let's objectively compare the outcome of the different treatment strategies and see how they fare. This idea, pioneered by St. Thomas Aquinas: to one who has faith, no explanation is necessary, and to one without faith, no explanation is possible. And we swing between the dangers of excessive optimism, where the religious zealots could fall into, and resistant skepticism, which the secular scientist can fall into as well. And there's a balance between the two. And just because we believe in something doesn't mean it's true, especially from a scientific point of view. And we have to follow the advice of St. Paul and test everything and hold fast to what is good. And whether you come from a secular or a faith perspective, both groups' biases run deep and they influence everybody. So all of us have to take a step back from our biases and say, well, let's subject our interventions to objective scrutiny that stands up independent of a person's philosophical view of the world. So what we do with restorative reproductive medicine and neofertility, we use a multiple index method using calendar, mucus, temperature, and urinary hormones to identify the biomarkers of fertility and record these markers. The fertility advisor is key. Without well-trained fertility advisors, this whole thing falls apart. And this is what we hope to see with our recorded, just put this up to the corner here, hopefully, with the app that at chartneo.com. When you document our data in a very precise, specific way, we can identify what I call the ovulation event, or the day of presumed ovulation, identified with the last day of good mucus, verified, so our primary indicators of mucus, and we would say, well, the mucus suggests, and the temperature shift after that mucus change validates what the mucus is suggesting. The LH surge is the third best indicator, where we look at urinary hormones, and we can document this under the test section of our app. And then you're aware of all the other things we would document as well. But the key thing, when we're going through our assessment, we want to assess the bleeding pattern, we want to look at the mucus, and then we want to test the blood 7 days after that ovulation event to see what is the quality of ovulation. Because we know well the woman is ovulating because she's having recurrent miscarriages. So a lot of my colleagues would say, well, if she's ovulating, our question with the day 21 progesterone is, are you ovulating, yes or no? And we know you're ovulating because you get pregnant. So why would we do a day 21 blood test? Because we know clinically you're ovulating anyway. The assessment for day 21 progesterone is more often offered for an infertility scenario to say, well, if it's below a threshold of 30 nanomoles, and some places are now even suggesting, well, even 20 nanomoles means you're ovulating. So if it's below 20 nanomoles, then we'll say that you're not ovulating. So it's understandable why they may not recommend investigating this, because of the question that is trying to be answered with the day 21 is, are you ovulating, yes or no? Our question is, when you ovulate, between 6 and 9 days later, when we're at the maximum surge of your hormones in the mid-luteal phase, what is the quality of your ovulation? Now, if we determine you have a suboptimal ovulation where these blood levels are low, we still don't know for sure, is that due to poor follicle function or corpus luteum insufficiency? And very much when it comes to recurrent miscarriage, I would typically recommend luteal phase treatment, specifically with HCG injections. And if that isn't adequate to restore optimum hormone levels, then add some follicle stimulation as well. But that way you'll minimize the probability of having a twin pregnancy. Luteal phase progesterone on its own, for most, is inadequate and not a great idea. And HCG would be a superior treatment. This is a fascinating new development. If we're struggling with limited mucus and poor temperature recording, then we have a beautiful evolution in urinary hormone testing where we can document, there's several different companies that do this, but we can document a combination of the estrogen detected in the urine, followed by the LH surge, followed by the progesterone surge. So we can plot the surges of all these hormones. And when we see estrogen levels coming down and progesterone levels going up, then we can identify the presumed ovulation event, because unless you have ultrasound and you visualize follicle rupture, you can't say for certain, but that's a presumed ovulation event, but pretty likely in cases of recurrent miscarriage. And this is a radical new departure with restorative reproductive medicine generally, where we can document the biomarkers of your fertility and we can identify an at-risk cycle before you have your first miscarriage. So our colleagues are saying, well, really 2 miscarriages is about the earliest we can say that there is an issue with recurrent miscarriage, but we can identify at-risk cycles even before you try to get pregnant. So this is something you really need to sit with and discover the radical new evolution that's occurred in restorative reproductive medicine. Credit would have to go to Dr. Thomas Hilgers for being the original pioneer to come up with this idea through Creighton Model and NAPR technology, which I worked in originally. And since 2016, I've worked in neofertility that we've developed ourselves. But other systems can now pick it up as well, depending on the level of training of the physicians. You can pick it up with your Billings chart, with your symptothermal chart, and the key would be the level of intervention that your physician will apply based on the information they receive. But in particular, we can identify these at-risk cycles, the late ovulation suggestive of polycystic ovaries, the very short luteal phase, very indicative of corpus luteum insufficiency. And these are indicators, they're not rigid and absolute. So if somebody decides they want to take a chance, you as a teacher or fertility advisor could tell a couple who are just using this for fertility awareness and family planning, you could say, you know what, you have an at-risk cycle. I know you may be planning to have a child soon. It may be wise for you to go to a doctor who specializes in restorative reproductive medicine for targeted hormone assessment to interpret the quality of your ovulation to guide you. Should you balance your hormones before you even attempt conception? And in that way, you will enhance their fertility to make them more likely to conceive and also less likely to miscarry before a even officially exists. So, and there will be people who will opt not to go for assessment and treatment, and they need to be free. And there will be people who will get away with it. And the younger you are, the more likely you'll get away with it. So you can't be absolute or rigid when it comes to fertility, but you would say on a population basis, it'll be more frequent that we'll experience infertility or miscarriage when we have suboptimal charting patterns. But people do need to have a degree of freedom as well. And they could get away with it their first one and not get away with it the next one when they get that little bit older as well. So, and it depends on a couple's level of comfort and how much intervention they wish to have. But at least you can give that information and say, well, we don't have exact numbers worked out, but we do know it is suboptimal and at risk and worthy of a further assessment. We have multiple sustained interventions with restorative reproductive medicine, and I start on the left and work towards the middle and eventually out towards the end. And I try and leave surgical intervention to later in the process, unless it is something very obvious, suggestive of a surgical problem. But very commonly, we'd start with diet and supplements and dealing with thyroid or low endorphins and correct these things first. And more recently, low DHEA, massive, especially when people are busy, tired, and stressed, and also insulin resistance. And I would attribute to FEM and to the work of Pilar Vigil for really raising our awareness of the importance of insulin resistance testing and treatment. And we're all doing more of that thanks to her very good work. And then our bread and butter treatment, when we've got our hormone assessment complete, then we do our follicle stimulation, our luteal phase HCG as needed, and we try to balance everything. And then we've got antibiotics and immune treatments that really, really do help us. And I would cry if we weren't allowed to give these treatments to our patients, because clinically it just works, but we really, really need to publish on this. And so phase 2 is when we've identified the problems. Then it takes us on average about 1 or 2 cycles for most patients to complete phase 2 and restore a normal balance. And phase 3 is we've identified, corrected, balanced. You're now ready to enjoy being together during some of the fertile days. And we deliberately use those words because if you say, the app says the days are here, the pressure's on, you really need to try, you're just really hindering their ability to conceive. So you keep this light-hearted, relaxed, pleasant context and don't allow pressure, stress, and intensity to creep in, or our conception rates will be delayed and impaired. So let's look at a case report. It's one thing having our theory, and it's another thing looking at a case and to try and contrast this with the general miscarriage approach compared to the approach that we take with restorative reproductive medicine and neofertility in particular. This is a couple who presented female age of 34, male age of 35, and they had been trying to conceive for 4 years. And during that time, they got pregnant 5 times, but every time it ended in miscarriage. So they had unexplained recurrent miscarriage, and statistically, she has a 50% risk she's going to have a miscarriage the next time, with just looking at purely that aspect of her 5 previous losses. So she came to me in February of 2021. We took her history and examination, and as part of her history, we discovered that she had her 4 miscarriages. She started when she was age 30, and by the time she was age 34, when she had 4 miscarriages, she had full investigations at the miscarriage clinic, and all of her tests were normal. This is in the August of 2020. She did the thrombophilia screen, parental karyotyping. She did infection screening. She did ultrasound of her ovaries. She did her thyroid function testing. So they followed the miscarriage guidelines through the hospital she was with in the miscarriage clinic, and they didn't find anything. So the recommendations were for intervention, we're going to give you a high dose of folic acid pre-conception. They give 5 milligrams usually of folic acid. We're going to put you on, once you are pregnant, we're going to put you on aspirin and blood thinning medication, which is terribly flawed logic. And that the evidence says that I showed you earlier from the miscarriage guidelines, if you do the testing and it's normal, don't give aspirin and blood thinning medications because it doesn't help. So you shouldn't do that. But it's just a sense of they want to do something. And there's certainly no guidelines to say, let's just give you a high dose folic acid. zero in that regard. And it's just a physician with a heart for the couple who wants to do something more than nothing. And then also, we're going to give you progesterone once you're pregnant, right through to 32 weeks. So I applaud the obstetrician gynecologist's desire to try and help. But sadly, if you don't do the preconception assessment and hormone balancing, it's too little too late just trying to give this once she's pregnant. And unfortunately, the published studies on cyclogest or progesterone show that it's effective if you're bleeding for the early stages of pregnancy. It's not so effective if you just jump in and give it. So that was their plan, all of these things. And they followed the advice. They took the high dose folic acid, got their positive test, did all the injections, did the aspirin, did the progesterone, goes in for their scan 3 weeks later, not a viable pregnancy. And there are 3 long weeks where you're waiting, hoping that we're going to get a good result. We've done all the investigations, everything's normal, we've done all the treatment. So that's what they were through with the recurrent miscarriage approach, standard guidelines, ineffective. So that's what they were like when they came to me. That happened in October of 2020, and they came to me in the January or February of 2021. So there she is, about a 50% risk that she's going to get another loss. And they're all around the 7-week time, and she's had 5 ERPCs or D&Cs. So that can make the cervix lax. And I would flag that to say I'd be much happier if she would have a suture put in the cervix, because if you get cervical incompetence, you don't know about it until you have a loss at 20 weeks. Now, it is the obstetrician who ultimately needs to make this call, but I would flag that and say, really, really ask them, because with repeated instrumentation into D&C, I think that would be wise. So the miscarriage guidelines have nothing more to offer this woman. IVF is not an option for this woman, and they still have a problem and say, well, look, we do the supportive care, it's 50-50. Let's flick a coin, maybe you'll get the right side of all of this. But that 50% chance of success is a live birth, premature delivery, low birth weight, unhealthy mom, unhealthy baby, high risk. No data on that. It's just live birth. So if you get a premature baby, we got there, we've success, say, well, kind of. And we don't have good data on the incidence of these pregnancy complications that badly need to be documented. You can't just say 50% success and not give us more data than that. So this is from the patient intake form that we use, and her BMI was fine. They were non-smokers, modest alcohol, caffeine, really not that bothered about it. And most people I find have taken too many supplements by the time they come to me. But look at this. She's got long cycles, 38 days on average, sometimes up to 42 days. Straight away for me, that's follicular dysfunction. And the commonest thing I would find would be polycystic ovaries. And that's something that I'd want to treat in advance. So longish cycle, I'm thinking along those lines. I'm also thinking she's over supplemented. Stop all of your supplements is my current advice. And let's do the bloods to see where we are. But unless they have a horrible diet or malabsorption, they're usually over supplemented, and excessive supplements are detrimental. So next slide. These are the symptoms to suggest she may have endometriosis. And the caution I would say is if she's had that many losses, the work in Omaha, Nebraska would tell you from Pope Paul VI Institute, there's a 70 to 75% chance she's going to have endometriosis there. They didn't tie in their data with symptoms of endometriosis. And I'd say, well, it's probably more 50-50 because you've no symptoms, and I hate to put you through unnecessary surgery. Interestingly, she's no symptoms to suggest polycystic ovaries. She's no body or facial hair, no acne, and her body weight is good. So there's nothing there really clinically concerning. And clinical endorphin deficiency, which is a common one that I would look at to boost the endorphins, well, maybe a little bit. That this is where I give low dose naltrexone to treat things like anxiety, fatigue, low mood. People often underestimate the level of endorphin deficiency they have. So to be honest, I can't remember what I did. We'll find out in a second, but off the top of my head, if I saw her today, I'd probably give her 3 milligrams of low dose naltrexone because it does have a positive immune modifying effect. And I would just judge clinically then, did she feel any better with it? But it's an ideal opportunity to try it out on day one when she comes. So I was also wondering about low DHEA, but clinically she's not strictly endorphin deficient. So we did her diet, got rid of her supplements, provided the emotional support, and I was concerned she might have low DHEA levels as well. Normally, I have that in the background and say, don't take the DHEA until I get your blood results back. And I'm currently saying the same with your vitamin D and your B12. So let's see what your levels are like before we give these interventions. So there I was saying, well, we'll start your DHEA if we get your results back and they prove it. So I must have been clinically suspicious of that. And then I was thinking, let's check this quality of your ovulation. I like this term 7-DPO, 7 days post ovulation, because peak day gets confusing with other terminology. And this is very precise terminology, 7-DPO. So it's a good one to try to start using. Was keen to get her insulin resistance, immune testing for NK cells, and I wanted the DNA frag testing as well, because clinically I find these things help. Her routine bloods for FSH, LH, prolactin, all good, all normal. DHEA is low, and her AMH is high. And so that is suggestive to me of polycystic ovaries when they have higher AMH levels and follicular dysfunction. Her B12, levels were fine, and her thyroid was fine, and we did insulin resistance testing, and the numbers all came in fine. We got a reading of 8, 32, and 19, all really within acceptable parameters, and she does not need a diabetic tablet for that. Now, they're the parameters that we use to see, and it's within normal parameters. We did her NK cells and they were normal. So great. I'm not giving you steroids during pregnancy, and his DNA frag is normal. We don't need to worry about the male side regarding DNA damage to the sperm. And that's really, really useful information. So, so we tell the guys, well, your role is you download a copy of the app, use the same email, same password, you document the medications, the bloods, or whatever else. But between the two of you, your role is going to be more supportive. But don't take supplements, because if you take supplements that you don't need, it may disrupt a balanced DFI. So look at her cycle. She's got ovulatory day 21 progesterone. So my colleagues are all saying, you don't have low day 21 progesterone, you're ovulating. And jumping off the page, I can see brown bleeding. I can see a late peak day, limited mucus, and I can see suboptimal hormones in the mid-luteal phase. So straight away, this is jumping off the page to me. And on the next slide, so we said, we're going to do your diet, your supplements, your emotional support. We're treating your DHEA. And I did boost her endorphins with a low dose of naltrexone. She had clinical thyroid dysfunction. That goes with low DHEA levels, where I give T3 treatment. It's a clinical judgment call. And her picture is jumping out at poor follicle function, and she brown menstrual bleeding. You get pregnant, you could tell this couple before they had their first miscarriage. You could say, you've got an at-risk cycle. You've got a late ovulation, limited mucus, brown bleeding. This is an at-risk cycle before she has her first miscarriage. So you have potential. So here she is, 4+ years trying to conceive and 5 miscarriages later, and the whole fertility world can't really help her. Whereas you could alert her and send her to somebody in restorative reproductive medicine and save her endless problems before they ever even try to have their first pregnancy. Her second prescription, some of these things were the T3, Pibon is a clinical judgment call, but I went for follicular stimulation with letrozole, 5 tablets day 3 and day 4. I gave her a trigger HCG because while I'm improving her follicle function, I can interfere with her ability to rupture, and I gave a HCG trigger for that. Very commonly now, giving a low-dose steroid instead of that injection, and it works well, and you can avoid the need for an injection. We give it for about 2 weeks. We start on day 7 and we take it for 2 weeks. Low dose prednisolone 5 milligrams or dexamethasone 0.25. So that's a change that I've taken on recently. And then she had luteal phase cyclogest, and she had low dose naltrexone. So I overstimulated her cycle on the first month, but you could see her mucus dried up a little bit. We gave her HCG trigger. 2 days later, identified her day of presumed ovulation. Blood's just a little high. Normally, I'm double checking by ultrasound. So I expect I probably dropped her dose of letrozole for the next cycle. So we'll see. I also gave her antibiotics. So the brown bleeding, I suspected a low-grade endometritis. So that's the mix of antibiotics that we gave. So you can see that at a glance. And again, I gave her another cycle of avoiding, so 2 medicated cycles. She was a bit reluctant to taper down. I would have preferred a lower dose again of letrozole, so she only dropped it by 1 tablet. And in this cycle, then her bloods were just perfectly balanced within normal parameters. So, but my preference would be even a little bit lower. But look, the mucus improving, and often the antibiotics will do that. And my hope is in the next cycle, her brown bleeding will be gone. But now we're in the zone. Next cycle will be her third medicated cycle. We've done her 2 cycles of assess and of boosting and balancing. And after these 2 cycles of lead in, the next one, we've got the green light to conceive. And a caution with our recurrent miscarriage patients is you may not get pregnant for a year because there's a haunting from those previous losses that can stay with you, and a stress and a worry and anxiety. And for managed expectations and our clinical experiences, it often isn't going to happen until you're between cycle 5 and 8. So make your peace with that. And it's good you can validate that advice to people once they have their balanced cycles. But and often at the same time, these people report back to me feeling clinically much better. And this is somebody who didn't feel too bad, so she'd at least be neutral. I don't want you feeling worse. So you feel the same or better, we're happy. Next one. So if we look at our multiple interventions that we recommended, these are all the things that we did. So you can see, and this is where the art comes in. How do you know what to do, when to do it, and which ones? How do you know when to do the antibiotics, and what are the right levels, and how do we do one patient versus another, or when do we do the ultrasound? So this is where I think doctors need to observe other doctors in clinical practice to get the clinical experience, and then practice themselves and attend ongoing continuing medical education to make sure they're up to speed with it. But it's a beautiful treatment because people feel so good on it very often. And then this is the idea where literally we say enjoy, and we give these words of you are done with trying to get pregnant. You look after each other, the result will look after itself in its own good time. We have a lovely balanced cycle. Everything is in the zone. I really like the look of this. And she's under 10 tablets of letrozole. Brown bleeding is gone. Mucus is only 1 day, but that's all we need. I don't sweat the mucus enhancers that much. I just give them the green light to identify and use the fertile time and avoid most mucus enhancers there. So that's an evolution in our practice. And this is cycle 9 into the program. And the previous one, if I can see it, where was it? That was cycle 9. Don't have all the cycles documented, but if we're looking at 2 cycles of assessment, 2 cycles of preparation, so it's about the fourth balance cycle or fifth, fertilization finally happened. So this is just looking at the cycle. And the month it happened, those bloods went a little bit too high. So it's this balance between, gosh, I really don't want a twin pregnancy. And I would have preferred if she got fertilization with a lower level of her hormones. And this is the other thing, and this is something you can do as fertility advisors, that the last menstrual period date is for a presumed ovulation on day 14. So if you know they've ovulated 3 days later, I put a little C on it for the corrected LMP, that 14 days before that presumed ovulation day was out here. So this is the date I give her for her corrected last menstrual period. 14 days later is where she ovulated, and then we can calculate her due date. I use yourduedate.com. It's a really good website. Put the data in there and it plots it out beautifully, so we know exactly down to the day and how many weeks and how many days is she for each blood test as we progress. During pregnancy then, so we've laid this big foundation. If we go right the way back, look at all the things we did preconception that my colleagues ignored. Compare that to just folic acid 5 milligrams. It's a different planet of intervention. It's a completely different level, and we get completely different results, and we get it repeatedly. So this woman who's had 5 losses, I'd be ambitious for her to have repeat pregnancies as well, because we know how to crack the code. And then when she's pregnant, yes, we're giving that progesterone. She may not even need it, but I overtreat that a little bit. I hate the aspirin and heparin because you've no logical basis for taking it, but she was strongly advised elsewhere, and it's hard to get them off that. And maybe I need to show them the published evidence and say, you did the test, no more than her NK cells. You did the test is normal, don't take this, you do not need it. And challenge them with actual published evidence in that regard. And then we'd stick with her diet, our supplements, her naltrexone, and she needs the DHEA, especially if her estrogen levels are low. Um, our DHEA data, I hope, will be included in the next revision of the miscarriage guidelines, because if you do a search using AI on the web, our publications come up to show that DHEA, if you ask the question, does DHEA treatment during pregnancy reduce the risk of miscarriage? It's strongly in favor of it, which is lovely to see. But we didn't publish that until 2024, and they only looked at data until 2021. So I'd like to think they could say, well, it's low level because we don't have a randomized controlled clinical trial, but there is evidence and it was statistically significant and clinically this works. So I'd like to see more people doing that. So during her pregnancy, we continued DHEA with her cyclodrest, naltrexone, and these supplements. And then we watch the hormones as it progresses. And this is a beautiful thing that we do. So that long 3 weeks while they're waiting for the pregnancy scan, we can predict with accuracy of 9 times out of 10, I can predict when I see the blood results coming in, do we think we're going to get a good one or not? And it's so important. Don't do a scan at 6 weeks and 3 days. It's way too early. You won't find a problem in the embryo. You may see a little heartbeat, and for me, it's often false reassurance. And a lot of places do it because they can, and they're all nervous as well. You have a better ability to predict if it's going to be viable based on the blood test results. It's superior to an early ultrasound. The only reason I might recommend an early ultrasound would be to exclude an ectopic pregnancy. But looking at these blood test results as the pregnancy progressed, straight away I dropped her cyclogest down to once daily. In fact, I should have stopped it because her levels are so good. Her progesterone, estrogen, HCG were brilliant. It was actually 8 days later, so down to every day I want to know where's that blood level. Bloods were absolutely beautiful, surging fantastically well. I'm looking for a tenfold surge on the HCG over the space of 7 days. We're going way above that. So it went from 200 up to 8,000. Brilliant. I got a 300 surge on the estradiol. Fantastic. Exactly what I hope. Progesterone came down a little bit. Well, it started too high anyway, and it's getting down to more normal level. She needs the DHEA 10 for sure. So I'm keeping her on that because it's just normalized her levels. I got a beautiful graph that I give to people, and we can share that with yourselves as well. So you can see the normal levels of estrogen during pregnancy. Just if you're curious and you'd like to know, be able to advise people, but ultimately let the doc ultimately advise, but good for you to be aware. So on the basis of these blood test results, with 5 previous losses, I'm not 50-50 with her. I'm 90% confident. And I'd say, well, leave your scan to 7 odd weeks. I prefer the 7 weeks, 3 days. I can live with 7 weeks, 1 day, fine. So she came to us that day and I said, already I'm 90% confident. Just do your bloods weekly. Don't do the bloods more frequently than that, because if you do them too soon, it's not going to tell you much. And these 3 bloods, that's the perfect balance of what to recommend. So then her bloods were, this is on the day we did her pregnancy scan, as it turns out. So after I did the scan, confirmed everything was okay. Look at these amazing bloods. They were absolutely brilliant. So, so there's the point that you can't tell if an embryo is in trouble with an early ultrasound. So she came in 7 weeks and 1 day. We got a 7-week size by the crown rump length and a 1 day discrepancy. That's agreement. You don't worry about a 1 day variation. And the fetal heart rate is 133. And I'd often say, come in 2 to 3 weeks later to make sure. So she comes in 8 weeks and 4 days, and now you can see the shape of the baby and pregnancy progressing very well. So with this second scan, I'm 95% plus confident this little one is here to stay, and it should be no more higher risk than anyone else's pregnancy. And because we've identified and corrected all these things pre-conception, and we monitor and manage throughout the pregnancy, she's going to get a full-term, healthy mum, normal baby, normal weight most of the time. So when I say, well, we're always respectful until you're at the end of the process, but it seems very promising and no red flags we could identify. We follow the progesterone curve from the Pope Paul VI Institute, which I think is probably set a little high. So I'm okay if the levels are coming near that lower dotted line, but if they're below that lower dotted line, then we definitely keep your hormone support going. And then we have our DHEA during pregnancy, and a beautiful graph we've developed for when you're about 30% below the mid-range, then it's a good idea to continue your DHEA. to get it above that lower limit. I don't like it being more than 30% below that mid-range. And we followed her levels right throughout the pregnancy, and broadly eyeballing this, it looks like we stopped her DHEA and her estrogen continued to surge very well. And very late in the day, I think we may have brought some small amount of DHEA back when she was 28 weeks. It was just a little bit low. So I just added DHEA 10 at that very late stage because her estradiol levels, they should be up at 40,000 and it dropped down to 28. So, and sometimes you find, oh, I'm not sleeping, I'm stressed or whatever. And it's just good for a pregnancy. And here's the point I would argue that with combined antenatal care between the GP and obstetrician, they don't measure the two most important hormones of pregnancy, your progesterone and your estrogen. And if they did measure them, they don't plot them on a graph, they don't know how to interpret them, and they don't know how to treat them. So I try to explain to our patients and say, well, we're doing something new that your GP and obstetrician doesn't do. Let them do the things they always do, but only let us guide you regarding testing, interpreting, and treating your progesterone and your estrogen. That's our area of specialty that they don't have any expertise or specialty in. So that's how I explain it to them and try and progress. And then here we go. And this is the message that she gave us. So she had a slightly lighter baby, and that was red flagged by that estrogen dipping later on, actually. So, and also he was 3 weeks early. So go, what went on there? That was a bit unusual for us, as it turns out, because I'm looking for the 7'7" our average birth weight. But she was delighted. Now, baby boy, maybe probably shouldn't have the name there. And he's born 3 weeks early, and he had a section. He was a breech, and his waters broke, and he's just perfect. So they can't thank us enough, and they made the dreams come true, and are forever grateful. And I'm ambitious for another one. I really, really am. And it's well within our capacity to do that if it's something the couple want to do. So, and that's it. We're highly likely to help them get a repeat successful pregnancy. And our plan is you treat for 2 cycles before you get pregnant. And the analogy that I use is, well, before you build a house, you lay a solid foundation. And that's what I would tell these to do. So lay your foundation and then you build. And we can do this repeatedly. I remember I had one couple in particular who had 7 recurrent pregnancy losses. And they went on, had 4 consecutive successful pregnancies with no more miscarriages once we got to the root causes and corrected everything preconception every time. And my learning lessons would be I'd use a slightly lower dose of letrozole to help us avoid having twins. And really, we've got to stop those blood thinners because they're completely unnecessary in her case. So they're the references that you could look at as well. And I think that's everything I have got. So thank you for your time.